Okay, so we're live. I'm going to give everybody just a few more seconds to join the call before we get into the presentation. Okay, so thank you so much, everybody, for joining our webinar today. So today this webinar is hosted by MedMastery, and we have a very special expert with us today. And our topic is on AI scribes for clinical practice. And I just wanted to offer a few words before we started. So a few words on what MedMastery is. So MedMastery is a platform which offers video-based courses on essential clinical skills. And that includes things such as MRI, CT, mechanical ventilation. We also have courses on cardiogenic shock. We also have courses in neurology, and much, much more. So if you don't know about us yet, make sure you go ahead and learn about us after this webinar. And we'll also even have a little discount code for everybody to join our platform and join our Pro Med Mastery membership. So I also wanted to introduce myself. So my name is Noor, and I'm a medical doctor, and I'm working here at MedMastery mainly on the AI webinars. And yeah, I'm really excited to get to know everybody here today. We're actually doing these AI webinars monthly. So almost every month we have a webinar which spans on the topic of AI in medicine, and we're looking at this from different aspects. So make sure you join our next webinar as well. And I wanted to introduce everybody to our expert for today, who is Dr. Verma. He's a dual board certified physician in internal medicine and clinical informatics. And he has many research interests. Just by the way, just let us know, guys, if you're not able to hear us well, let us know in the chat so we can figure it out. But yeah, so I was going to tell you guys about our expert. So he has many research interests, such as the safe and effective use of AI in healthcare, reducing clinician cognitive burden, and improving clinical outcomes using technology. Dr. Verma, thank you so much for being here with us. Could you let us know what prompted your interest in these different research projects that you've been involved in?
Yeah, absolutely. Thank you, Dr. Al-Shari, for the kind introduction. Hi, everyone. So I'm Richie. Yeah, my journey started a few years ago. So I was practicing as a hospitalist in Boston area, and I think one of the biggest things that kind of bothered me in my practice was this a lot of clinician cognitive burden and some of the burnout that would come with that, a lot of the administrative barriers and administrative burden that writing notes and just like documentation, like duplication of documentation, three different versions of the same documentation. So those were like some of the pain points in my practice and my colleagues' practice that I was noticing, which led me to pursue sort of education in my other sort of affinity for technology in general. So I started learning about the AI, machine learning, which led to getting involved in the project, pursuing a fellowship in informatics, which I just finished. And so that's what led me to getting involved in some of these projects. So those are direct results of like my passion, the barriers in the care that I see from day to day. So even like when you have patients with multiple problems, so many things that you need to do, but at the end of the day, you still have this documentation that you have to do. So I think that was like one of the biggest challenge and barrier I felt in my practice that led me to, okay, let's see what we can do about it.
Yeah, thank you so much. I think a lot of clinicians can relate to that.
Yeah.
Okay, so before we get into the contents of the webinar, I want to let everybody know how you can use our platform here today, especially if you're new to these webinars. So to the right of your screen, you can see three like little icons. The one at the top is the chat. The one beneath that with the little question mark in it, that's where you can submit your questions. So towards the end of the webinar, we're going to have a Q&A with Dr. Verma, and he's going to answer some of the audience questions. So make sure you submit them there so that we're able to organize the questions better. And then below that, there's a little polls icon, and that's where Dr. Verma is going to be testing our knowledge on some aspects of the presentation, and that's where you'll be able to answer those questions. So the little polls icon to the bottom. Okay, and then I want to ask everybody to stick around to the end of the webinar. This webinar is going to run for approximately an hour and 15 minutes. So make sure you stick around to the end because we're going to have a present for everybody. And I'm also going to let you guys know where you can find all of our previous webinar recordings. Okay, so I'm done with my introduction and I'll hand over the presentation now to Dr. Verma.
Yeah. Thank you. All right. So just want to verify, are you able to see it?
Yes, we can see your screen. Looks good.
All right. Thank you. Well, welcome everyone. So today I want to talk about AI scribes use in our clinical practice. So lately, over the last couple of years, since we've learned about what ChatGPT can do, everyone's been looking for how AI can make their lives much better, and clinicians aren't the exception. So we are doing the same thing, and we're looking for the ways we can improve our practice. And one of the technology that has come forward and people have started implementing and adopting is the AI scribes. But I want to take a look at what AI scribes are and what are the limitations of this technology right now in the beginning of 2026. So in this talk, we're going to see what role the AI scribes play and what value they provide to our clinical practice. We want to review some of the limitations and the potential pitfalls that people have identified so far in relatively larger scale studies, studies from the bigger institutions that are not coming from the vendors themselves, so with the less bias. Understand what the safeguards that we have currently in place and what safeguards do we need for the use of this technology in the future. Because as we have learned about the AI technology from other domains, is that it is not perfect, and we'll see in what ways the technology is not perfect today. And then I will review some of the best practices that we can employ to make sure that we're using this technology safely and doing best for our patients. And finally, we'll take a look at an example, a clinical scenario where we can see that how AI scribes can be used in practice and what to expect. So I just want to start my talk with this quote from ChatGPT, which is the technology should reduce cognitive load so clinicians can focus on clinical reasoning. So that kind of captures what I want to discuss today, that we have this technology. We've been told that this technology is good to reduce documentation burden and save you time. But time isn't the only valuable resource that physicians or clinicians have. More than time is the cognitive bandwidth or the task burden that we have that goes into being a clinician. That is another significant component of our practice that leads to a lot of burnout that we have noticed in other studies over the many years, last decade. I think it is really important with the use of this technology that what we want to see is that the AI scribes can help or support our clinical reasoning without compromising any safety, education, and professional judgment. Okay. So before we begin, Noor, if we could start with a poll question.
Sorry, Dr. Verma, we're not able to see your screen anymore. Are you able to share it again? Sorry.
Yes. Me.
Thank you.
Sorry.
No worries.
Are you able to see it now?
Yes, works. Thanks.
Okay.
Okay, so we have a poll question, which is currently to the right of your screens, and it states, which statement best describes what an AI scribe does in clinical practice? So, does it independently evaluate patients and generate diagnosis? Or does it convert clinical conversations into structured documentation for clinician review? Does it replace the EHR and manage billing and coding automatically? Or does it provide clinical decision support and prescribe medication? So let us know. There's a poll to your right of your screens. I'll give you guys a few seconds here to answer. Okay, so Dr. Verma, the majority of people, so around 80% of people are saying the correct answer is B.
Mhm. Yeah, so that's good. That's exactly right. So right now, what AI scribes are able to do is similar to what we would imagine from any scribe function. A medical scribe is that taking the clinical conversation and generating a clinical note for clinician to review. So the other options are really more of some of the things that people are thinking that down the line might be something AI would be able to help us. But right now, as the technology stands, we're only able to generate a static documentation. We're not able to do clinical decision support. Right now, we're not using it outside of the research domain for billing and coding for the most part, and we are also not using it to tell us the diagnosis. So before we talk about the AI scribes in depth, I want to take a look at what is underneath it. So as we just learned, the AI scribe is a tool. It's an AI, using an AI technology to perform the function that we used to have humans do. The medical scribes would create a note. They would listen to the conversation. And then clinician would go on and review the note and sign it. Similar to that function, AI scribes are doing exactly the same thing. They're just replacing the human component of that. Partly to the technology is cheaper than the alternative. Partly it's because that everyone can use it, and there are added benefits to the technology, that there's more sort of AI based understanding that comes into the notes, and the notes better align with the way we want to write our notes. So some of those things that people have seen, but what's really happening behind the scene is that the way it does is it takes the audio of a conversation between you and your patient, and it would take a look at that conversation and use an automated speech recognition that in itself is powered by the AI to generate a transcript. And that AI component ensures that people with accent or people with limited English proficiency, that the transcript is accurately describing what they're saying. Technology itself, which is large language model as it stands today, taking that transcript and generating a clinical note the way we like it, the way we prefer in the outpatient setting or in the inpatient setting. The reason I wanted to go over this is that I wanted you to see that there is a middle component which a lot of people never would get to see because they're just going to use the technology, press a button, and they'll get a clinical note. But there's always a transcript getting generated, which could have medical legal implications and could have privacy and safety concerns and could have the quality assurance, could be used for quality assurance down the line. So that's why I think it's reasonable to understand the components of AI scribes. Why do we want to use AI scribes? So as we've been talking about right now, that people imagine that AI would help them, one, write notes, so hence save some time writing those notes. It would free up their time so that now spend more time with the patient, talk with the patient, look at the patient when we are having a conversation rather than looking at our computer screens. And all of this would reduce our cognitive task load and reduce our burnout. That was the hypothesis going into it. And what evidence do we have right now? So the major studies, late 2025, that we have published from last year, are single center studies. So this the one on the left side is from Yale, where it showed yes, there is a reduction in the burnout after using. So when they did the pilot, and yes, there's a cognitive task load reduction about 2.5 point on a 10-point scale. And yes, indeed, there was some time that the clinicians were saving, like after hours, the pajama time we call it, and providers were pay undivided attention to their patients. So there was a 2 point increase in that as well. And there's another study from University of Chicago where they looked at time saving. Most of the data comes from the retrospective EHR capture, so take it with a grain of salt. But adjusting for the methodology and the limitations, there does seem to be some evidence of that you do save like 2.5 minutes each encounter. And even for note writing, this is real evidence with showing like 2 minutes is saved, but actually typing the note. Okay, so another poll question.
All right.
Dr.
Great.
Al-Shadi.
Thank you so much. Okay, guys, so we have another poll question, which is currently to the right of your screens. You should be able to see it in just a second. Okay, it should be visible now. And it states, so which clinical setting is currently most likely to benefit from an AI scribe? So is it a surgeon who's performing complex intraoperative procedures? Is it a primary care clinician, or is it a pathologist who's reviewing some biopsy slides? So I'll give you guys here a second to answer. By the way, Dr. Verma, would it be okay if you pushed the camera a little bit towards your face? Because when you're speaking, it kind of like cuts off your face.
Oh, okay.
It looks good right now. So
Oh,
it's
okay.
just when you're
Yeah.
speaking, it kind of moves away from your face. Thank you.
Yep.
Okay, so Dr. Verma, the majority of people are answering B for this one. So answer B.
Yeah, and that's absolutely correct. The idea is the hypothesis is that the most benefit would be to the people where there is a high documentation burden to begin with, and primary care setting is or outpatient clinic visit setting is exactly the type of environment where you would expect this type of technology to be mostly beneficial. The intraoperative note right now, as they stand, or the procedure notes, or the pathology reports, both of them have less to write, and most of this is a templated documentation, so less likely to be beneficial. Is there any evidence behind this? There's some evidence, not a whole lot, because the current implementation is primarily geared towards outpatient setting. So what they have seen is that yes, higher baseline documentation, you see benefit. On the surgical specialties, it is less commonly being used, this technology. But there are other subspecialties, like for instance, electrophysiology, where they're only dealing with like one issue at a time, the arrhythmias. They're not even interested in sometimes that like the underlying cardiac problem or heart failure or things like that. So when they get this AI scribe, which is writing a note very broadly, not focused to their specialty. So this is a lot of anecdotal evidence. A lot of my EP colleagues are saying, we don't want this because it's not helping us. Our templates are much faster right now. Okay, so now we've looked at the benefits of this technology. Let's move on to see what are the current limitations of this technology as it stands. All right, we can start with the poll.
All right, guys, so we have our next poll, and it should also be currently live right now. And this poll states, so what is the most common and clinically important limitation of AI scribes? So do you guys think that they're unable to generate good notes? Do they mischaracterize clinical details? Are they not able to enter into EHR? Or are they not able to document negative findings? So I'll give you here just a second to answer again. Okay. So, Dr. Verma, the majority of people, 80% of people say B, but there are some people who say A and C as well.
Okay. Yeah, no, absolutely. I think this is where I expected a little bit of divide as well. The correct answer is B. The inability to generate structured notes. So that's actually one of the strengths of AI, structuring the notes as we want them to. So you would put in the prompt. So I don't know if I'm sure many of you have already done some use of like ChatGPT. So that is like one of the strengths where, as you would want the output to look like, if you just say in the prompt, it would generate that type of output. So that is actually one of the areas it excels at. Whereas the integration part is something that I expected people to not know, but earlier stages back in 2023, 24, 25, when it was coming out, the technology was coming out, most of the pilot studies included this a standalone app where you would record the audio and it would generate a note. And then you would have to copy and paste that note into your EHR. So that was a limitation and was a very common limitation that made people not to use it in the beginning. But lately, since 2025, 2026, most AI scribe vendors, at least the big, large vendors in the field, they have this ability to integrate with the Epic and Cerner and some of the bigger EHR system. And being able to document negative findings, that is another thing that the AI is able to do. AI is to some extent trained on our notes, so it knows that a negative review of system, how important it is to our structure, and the AI is able to generate that as well. So reviewing the limitations, so the most common limitation of AI scribes as it stands right now is the problem with the accuracy. There are a few studies recently from 2025 and early 2026 from Yale that came out that looked at consultation-based usage. And they saw that in routine scenarios, accuracy can be as high as 89%. It's a routine consult. Things are as expected. The accuracy is really high. You're talking with the patient in a very structured format. Whereas in the acute care scenario where the problems are coming piecemeal and clinicians are making decisions one at a time, though in those situations, it can deteriorate even to 65%. So 35% of your note might have inaccurate information and you would have to edit. And then looking into the specific errors, the recent studies, most of them have shown that omissions are by and large the biggest error and a safety issue. So 40 to 83%, depending on which study you're looking at, because right now early studies are institution-based, single center-based. You would see that they're missing major components of the diagnosis or medications you discussed or the recommendations you talk with the patient. And Although hallucinations, which is where AI is making up information, making up diagnosis, and adding findings, is less common, 10 to 15%, 20%. It does require a lot of editing, and it can be really harder to detect because if you're not doing the editing right there and then, or immediately after that encounter, you might not remember some of the details. Furthermore, looking into the limitations, so we have to remember that all AI is trained on human text, in text on the internet, text in our books, but also text that has been taken from our EHR, electronic health records from before, where we have been documenting our notes for the past decade, decade and a half. And in the past, we haven't always been really good about the way we write notes. Just over the last decade, we have seen that we now have open notes and patients are able to see our notes. But before that, we were writing anything that we felt about the patient, that patient's not compliant, patient is a medication seeking, drug seeker, those type of labels. Those things, because these AI systems are trained on our notes, they will use the same language. Right now, unfortunately, that's the reality. Um, there's no The only way to fix that is you have to make sure your notes edited when it's done, and you remove those type of biased language. Furthermore, it might misrepresent speech. People with the speech issues, or even patients and even clinicians with accents, it might not capture exactly what's being said. Then on top of that, there's a risk of discrimination with the patients who are cognitively impaired, your dementia patients, patients with delirium, and then patients who do not speak English. In a lot of cases, you are not going to be even able to use this technology because it's not trained on the language of their use. And then finally, the denial of insurance coverage is where a lot of the insurance companies these days are using AI themselves to make algorithmic decision that who they are going to provide coverage and who they are going to deny coverage. And any kind of misrepresentation of your recommendations or the conversation with the patient can be put into the note, and that can become a so this makes it really important when you have a note that you review that note and edit it for those type of to prevent those type of issues. Furthermore, I think this is one of the biggest factor, biggest reason that a lot of people don't like AI scribes, and a lot of patients are saying that they don't want AI scribes to be used. A recent study showed that they were concerned about privacy as one of the biggest reason that they don't want physician to use an AI scribe because they didn't know where their recorded conversation is going to go. And that's a problem for clinicians as well, because a lot of clinicians themselves, they don't know where all of this information is going. Well, I'm sure a lot of clinicians don't even know that there's a intermediate step of like transcript is being generated, which is being kept with the vendor, which is a separate company, might not be limited by the same in United States with the HIPAA laws, but in other countries, different privacy laws. And but those companies, multinational companies, might not have those type of laws restricting them from the use of that information. And this undermines the process of informed consent, because if clinicians themselves are not aware of the issues with the technology or the the privacy implications, how are they going to consent to, or provide information to the patient to make informed decision? We cannot just use an end user agreement because this is not, we're not selling a software, we're their providers. And then furthermore, the issue with consent, how do you consent to dementia patients or patients with early dementia? Do you preemptively consent to those patients for future implications? And is the use going to be limited to clinical practice or research? And if it's only for clinical practice now and not using for research, now you're not using that AI to train the models for dementia patients. So it's going to, again, continue to have that limited implementation in the case of patients with the dementia, leading to that whole risk of discrimination, bias against the patients with the dementia. That's one of the examples. Or similarly with the patients with limited English proficiency or a language, if they're not trained in their language and you cannot even consent to them, then you're out of luck. And those patients, for those patients, this technology might not even evolve to that level where in future it could be more beneficial and prevent safety issues. Continuing, there are workflow impacts of using this technology. So if you have a lot of errors in the notes, we saw that in some cases it was 35%. You're going to lose a lot of the time that you would have saved. So people are not going to use the technology. If the notes are too long, it's too verbose, people are not going to use the technology. Although in some cases, early studies are showing that there might be a benefit here, that the notes written by AI are actually shorter than some of the notes that we have been writing, the copy and paste notes, but that's really too early to say one way or the other if, what sort of implication that would have. Then poor EHR integration. So granted, in bigger institutions where the EHRs, you have big EHR and your institutions and hospitals have contracts with the bigger AI scribe companies, you have an AI scribe software integrated into the EHR. But for many smaller AI scribe companies, this is still one of the limitations, that it's not integrated into Epic or Cerner or other EHRs. Then limited formatting options can also limit your ability to use this technology. For instance, as we just were talking about electrophysiologists, if there's no template for electrophysiologists, it's talking about hypertension or other cardiovascular issues rather than arrhythmias. EP doc is not going to use it. And then language formatting options, if there are so many biases, the notes generated have biased language, you're less likely going to use that technology. Furthermore, there are no standard regulations. So FDA has yet to authorize any large language models. So this is from late 2025. And I think even in early 2026, there's no LLM that is authorized by FDA to be used in the clinical setting. Current safeguards are only at each institution level. They have not been standardized throughout the healthcare system. And the early evaluation data is largely from the vendors. Most of the studies that I have put in this talk are from institutions, but if you go beyond like early 2026 and late 2025, earlier than that, most of the data was coming from vendors themselves. But there are more studies coming out, so we'll have more information. And continuing on that, AI can sometimes, this could become a limitation as well, and ability to identify errors when AI systems are using overconfident language. And then there's this component of automation complacency or a bias where you don't have enough time at the end of the day to review each note, or you just think that it's a computer generated note, most likely it's going to be accurate. Or in the past 5 notes, I've seen that AI has been okay. Maybe this note is okay too. So I'm not going to look at that and waste my time. Both of those conditions can lead to these overall decrease in accuracy, and those errors can get perpetuated, leading to potential safety issues down the line. So, reviewing those limitations, so it seems like there's still a lot of room for this technology to grow. But a lot of institutions are currently using this technology. So what are they doing to prevent these type of errors? What are the potential safeguards that are in place and that are being taught out? So before we go and talk about that, there's another poll question.
Yeah, so we have another poll question which is currently live. And this is what Dr. Verma was speaking about. So it's about the safeguards. So which of the following are important safeguards when implementing AI scribes? So we have a couple of options here. So is it the mandatory human review? Is it the governance, validation systems, and the workforce training? Is it the careful implementation, such as tailored prompts or onboarding? Is it the safety reporting systems and evaluation tools? Or is it just all of the above? So I'm going to give you guys a second here to answer. The polls are to the right of your screen again. Okay, so I see like majority of people have started to answer already. And Dr. Verma, the majority of people are saying E, so the last one. So over 90% of the audience says E.
Yeah, thank you. That's exactly correct. So all of these safeguards are important, and are some of these are implemented, and some of these are being implemented. So we'll talk about it. So as the technology stands currently, human review is the primary safeguard, unfortunately. And it is an expectation from every clinician who's using this technology right now to review their note at the end of the encounter to ensure that it's accurate. And it's clinicians' responsibility to ensure that accuracy. It has a downside. A major downside is that it is increasing your workload. So for some of the AI scribe systems that have an accuracy of only 65% or 70%, you're getting 30% of your node. That's a lot of work. I mean, people on the inpatient side might consider that's like our day's work, right? I mean, you're copying and pasting, and you only edit like 30% of the node. So what's the value that AI scribes are providing, you might ask. But that's the reality right now. But there are systems that we do need, and they are being created. The work is being done. The biggest one is that any institution that wants to implement AI technology has to understand the limitations, and they have to put systems in place to make sure that they are validating each tool that we're using, AI-based tools, and certifying these tools. And then we need to have error detection systems that are outside the human review, outside increasing the human cognitive burden or human task load. And we need safety and prevention strategies in our workplace. And on top of that, we need to train our workforce, people who are going to be using this technology. They need to understand, like this lecture is one of the examples, but these are the type of things that everyone needs to know, and everyone should be on the same page. So this should be a standard part of the education, similar to EPIC training or things like that before. And then at an implementation level, as we talked about, you need to tailor your prompts for specialty. If you're using it in the inpatient setting or for a diabetes doctor versus a primary care doctor, you need to have a completely different prompt, the way the output needs to look like, what are the things that are important. And so your informatics team has to work with your clinicians on that. And then onboarding and peer support. So new providers joining your service, joining your specialty and practice, you need to make sure that they are also on the same page. When they come in, they get educated in this whole process. Furthermore, we do need a continuous monitoring system and evaluation system because if we just assess them in the beginning, evaluate them in the beginning, and let them just be used and never to go back and see, in the past, we've seen that a lot of safety implications of like when we implemented Epic. Even for Epic, like the QI teams are doing every 6 months or a year safety checks. Epic analysts are doing behind the scene technology safety checks. So those type of situations we need to evaluations. We need to continue doing monitoring to prevent any harm. Then AI is not like your run-of-the-mill software technology. The issue with AI is that your regular software takes an input, generates an output. It's going to be the same output for the same input AI is going to be same input, different output every single time. So the permutation of outputs with the AI technology, you need more specialized context-based tools to evaluate, and then you need newer safety classification systems and reporting systems to determine are these tools working as they're supposed to. Despite knowing all this, right now at this stage, the beginning of 2026, there are critical gaps that are still persistent, which is we don't have a standardized protection systems. Intervention, most of the interventions are institution specific and primarily at a larger institution. Those are being implemented more stringently as opposed to in some of the smaller places. Lack of resources or for a number of reasons that those support systems are not there. There's no FDA regulations, and most importantly, all of these things we are doing right now are reactive than proactive. So we didn't think about these systems before. We've been doing this research. We have already implemented this technology, but now we're learning similar to in the past. So we need to also, because AI is evolving really fast, we need to increase the pace of our ability to evaluate these tools as well. Okay, so now we've learned the nitty-gritty of the AI scribe tools. What we want to see that what we can do, what's in our control right now, and what are the best practices when we are seeing a patient and using this technology. So before you go and see your patient, the most important thing to do is formally train your clinicians, formally get educated in the process of knowing what's the functionality of AI scribe right now, what are the limitations of these AI scribes, and what are the privacy implications? Because if you don't know anything, you're not going to be able to provide that information to your patients when you're doing the consent. Then we need a specialized training in consent processes to clinicians need to understand they know the purpose, but they need to understand the privacy implication. They need to know where the artifacts that are being generated, that transcript or the note, who is storing that information, for how long are they storing that information, and what purpose are they using that information for. And clinicians also need to understand the legal implications of doing that consent process. There are wiretapping laws. Each state have different wiretapping laws. So if you're recording someone's audio, you have to know that there's completely different set of guidelines and the consent that you have to do in not just guidelines. I mean, those are laws in some of the states in the United States. So you have to be aware of those. And then furthermore, how do you consent in a multi-party visit, or if you're using the technology on the medicine floor or ICU, you have many people present and during that discussion of the patient, and when you're using that scribe, or when you're talking with a non-English speaker, you need to be trained and educated in how to do consent with the people who don't speak English. Then, most important, you need to make sure that you can have this tool integrated into the EHR. That was, I think, the number one issue that people mentioned, providers mentioned in the very beginning, that we're not going to use it if we have to go on to a different website, sign into our account, and use it, and then copy and paste it into our notes. Then specialty specific customization, if you want it to be used more broadly into the more than just internal medicine outpatient. During the visit, address your patient's questions, any concerns that they have about the consent procedure, and any questions related to any component of the technology used. Making sure that technology is hands-free after clicking the recording button. Making sure that everyone knows how to monitor assess the usability issues. You have a team dedicated to ensure that the AI scribes are functioning as they're supposed to. If there are any malfunctions or poor audio quality, then those need to be regularly tested, and having contingency plans ready. So, for instance, at our place institution, we're training the interns into learning how to write your notes first before giving them AI scribes. So each institution, they have to figure out for themselves what you're going to do, because you need to train your workforce to be able to do their work when the technology breaks. Epic breaks from time to time. There's downtime. We have to use paper-based charting, paper-based orders in those situations. I'm using Epic as an example, but any EHR has the same issue, not just Epic. So that's the one I use mostly. That's why I'm using that as an example. But you have to have contingency plans ready for these type of situations. And then using some verbal best practices. These are some of the lessons we learned from dictation tools, like speaking in a structured format, using verbal cues like that this is the assessment, this is my plan for today, making sure that you are saying key negatives explicitly and trainees, if you're educating them, maybe pausing the conversation, recording while you're doing the education, and then restarting the recording for that session. So some of those verbal practices, don't worry about any of the grammar, but just make sure that you're labeling what you're saying or the conversation that you're having with the patient. Then after the visit is done, most important, immediately review your note. If you review it immediately, it should take you less time. If you leave it to the end of the day, it's going to depend on your workflow as well, how many patients you have scheduled for the day, but you're less likely going to catch those errors if you're doing it at the end of the day. And if you're leaving it for 2 days later, 3 days later, or at the end of the week, you're much less likely to going to remember the errors. Then think about where the errors could be: medication, diagnosis, dosages. Think about formatting of the note, fix that, make sure that it is appropriate for your use case. Note length as you want, and then tone and cultural sensitivity. And remember, any error in the note is a clinician's responsibility right now. And furthermore, ongoing concerns, seek regular feedback from your workforce. Ask them what issues they're encountering, or is it even helping them in the first place? You have spent so much money on this technology. Are they even using it? Evaluate any workflow impact. Is it causing any issues with them not being able to see the patient? Or is the audio quality poor? Or are they dealing with the tech issues more than they have to see the patient? Those type of things. And continue to evaluate the documentation burden. Is it even helping that? And then most importantly, seek patient-centered concerns as well. Ask patients whether they think that this is helping them get the better care. I also want to talk about some of the things as a clinician, some of the best practices that you can do when you're talking with the patient. What you need to do is ensure that you're using a very simple language. Don't use technical jargon. Use a concise language. Use the language that anyone could understand, whether they're technology suave or technology literate. The elements that should be present in each consent, you have to ensure that you tell them that AI is going to be in use. It's going to record our conversation and how it functions. That you are going to review the note before finalizing to make sure that it's accurate and accurately representing what's being discussed. Tell them what the benefits are, why you're using it to improve efficiency and reduce documentation burden, etc. Uh, Make sure you explain them how data is going to be handled and protected, privacy implications, and what your institution or organization or your practice is doing to monitor the performance, and what choices do they have that they are able to decline the use of the AI scribes if they don't feel comfortable, and this should not in any way impact the care that they will receive. You can use additional online or printed information if the verbal disclosures themselves are not adequate to provide additional information. the notes themselves should have at the end of the day, at the end of the note, a disclosure saying that this note is AI generated and then reviewed by a clinician, so that when patients are looking at those notes at their home, that they know what parts are AI written, or at least they know that the AI was involved. And then providing them more resources if they need any additional information, like a web page or they could talk with at your practice or institution. In terms of choosing an AI scribe tool, what are the things that you need to look for when you're, let's say, talking with the company, or even by yourself in a solo practice, you're evaluating a tool? You need to know primarily the most important thing is like what are your goals and what problems you're trying to solve. Because if your problem does not match the tool that you're bringing in, then you're not going to get the most benefits. So if documentation is not a problem for you, it's not, you use templates which are really efficient, then this is not the right tool for you. So you have to understand that. Then the other important considerations, as we talked about, among the limitations is that accuracy and the quality of the documentation. Look for objective data, not just the vendor specific studies or their own metrics. Look for usability issues and the EHR integration. There are usability studies that are coming out as well, so you can look for objective data, how clinicians are finding this, if it's impacting their workflows or not. Ask the vendors for specific things that have they done their due diligence, like what data security measures have they taken, what type of bias testing they have done, or what type of built-in performance metrics they are providing. Is there a dashboard that comes with that tool? And then, of course, cost and scalability are going to be each individual or institution specific. You have to take that into consideration as well. All right, so having reviewed all this information about AI scribes, I thought maybe we can just take a look at an example case to bring home all the points that we discussed today. So this is an example from a very simple example from an outpatient urgent care visit. So you have your patient coming in who's a 37-year-old person, male, with the chief complaint of cough and fever for 4 days, and it's the urgent care setting. So we'll walk through this simple problem and what you can do in that situation. Make sure that you have to not do a lot of editing after the documentation is done by AI Scribe. Okay, so, okay, before we go in and look at that examples, let's type in your ideas in the chat, what you can think that you could do to improve the quality and the safety of AI generated note.
Yeah, everybody. So just let us know what are your ideas on this question in the chat before we move on to the next slide. There's no poll that's currently live. Okay, Dr. Verma, there's no current responses. I think we can move on and just come back to it later if people start responding.
Yeah, absolutely. As we talked earlier, some of the best practices and one of the consideration or the thing that you can do when you're talking with the patient is ensure that you or the patient is verbalizing and enunciating the exact things that you want it to be in your note. So a lot of the time when we're talking with the patients, we're not thinking about specific the clinical elements, but think about that when you're talking with the patient, that what's going to go into your note, and when they're saying some things which are exactly the problems or the symptoms that you want them to go in your notes, verbalize those. So 4 days of cough, dry cough, for instance, or temperature of 100.8 Fahrenheit. So your MA or you have checked the temperature, verbalize that temperature. So some of these recommendations are from like the dictation tools that we used to use, but the benefit of the AI is that you don't have to worry about that you have to put which part of the note. AI will take care of that. AI will take care of the grammar. You just have to worry about the clinical element. So there's no shortness of breath, no chest pain or hemoptysis. So those are the exact symptoms, the review of symptoms that you want to go in your note. So verbalize them. When you're looking at this review of system, pertinent positive, fatigue is present, no nausea, no vomiting, no diarrhea. Physical exam in this example, so you mention, so you when you're listening to their lungs, just say it out loud after you've done your exam, lungs clear bilaterally. That way AI would know that this is what you need in your note, and you wouldn't have to fix it later. Oxygen saturation 98%, afebrile, any other components of the physical exam that you want to say, just put it in there. Avoid saying vague phrases like, oh, the exam was normal, because then it would generate a template and then you would have to do a lot of editing. Then using verbal cues when you're saying, okay, we think that this is most likely going on, that this is a viral infection. We don't think that there's a pneumonia. Say that this is my assessment. Use that word. Or when you're saying these are my recommendations, say that these are my recommendations, that this is the plan. Just label that part that you're recommending supportive care, you're recommending over-the-counter medications, return precautions, and no antibiotics, those type of things. And verbalize even the negative things that you want to be present in your note. So this is where the magic is going to happen. So AI would take all that information, the bits and pieces of information that you provided, and now AI has generated this really amazing note, the way we like to see our notes to be. So it's put all the information into right sections where we want them to be. The HPI includes all those symptoms that you talked about, the fevers, reported fevers, and the physical exam findings that you verbalized are all there, and then assessment and plan section, what you recommended, and then the patient instructions are generated, those type of things. Can you identify the errors in this output? Let us know in the chat. Dr. Al-Shari, I'm not able to see the chat. Are we getting any responses?
I'm just giving everybody like a minute to answer because for the last one, people started answering.
Yeah.
Oh, moved on already. So I'm just going to give you guys a minute here to answer. So is there anything that you can identify in this note which is incorrect based off of the case that Dr. Verma presented? Someone says the O2 saturation.
Mm-hmm.
I don't know. Okay, so I think we can move on and show people what is wrong with this and let people answer in the chat whilst you're showing us.
Yeah, absolutely. So this is very simple scenario. I wanted to introduce it to ensure that we understand what are the type of errors to expect and how subtle some of these errors can be. So as I was talking earlier, that there are two large bucket of errors. One is omission. You did something or you said something, but AI didn't put it in the note. In this example scenario that I have put together, there's only one omission that you talked with the patient. They denied a chest pain, but it forgot to add it into the note. But there are these other examples which are very subtle, and if you're not careful, you're going to miss that the cough is productive, but the patient reported the cough was dry, or the physical exam, you did not mention heart sounds are normal, And this is where, as I was telling you earlier, saying that what you want to be present in your note is more helpful, because otherwise it's going to start adding some of that information because it's been trained on our notes. And it sometimes the AI itself would start adding some component like templated sections that you probably don't want to be there, even if you did not do that component of the exam. Like for instance, this is a primary pulmonary issue, so you might not have done a neurological exam in this patient, and it might add neurological exam in there as well. Then looking at the assessment and plan, it's saying presentation is consistent with the viral URI, whereas you were hedging when you were saying that it's probably URI, that your suspicion for pneumonia is low. So these could be like subtle findings. It might not be exactly the way that like I have put together the same errors, but these errors can be like this subtle to recognize. So what you need to do next is then make sure that symptoms are accurate, make sure that the negative findings are the right negative findings, and adjust the diagnostic certainty or uncertainty, and then remove any of the um, exam elements that you did not perform. So this should take you about 30 to 60 seconds. In this scenario, more complicated cases, the longer notes, it would take you a little longer. And then finally, you sign your note, which should represent accurate and concise documentation, appropriate diagnostic uncertainty, and it should then have a clear plan, return precautions ready for billing and compliance. So with this example, we see that even for this note, this simple note, it would have taken you 5 to 7 minutes to go through this encounter, writing a note without AI Scribe. Whereas if you use the AI Scribe, it would have taken you 30 to 60 seconds. There's much more cognitive load because this is not the only patient you're seeing for the day. So you're not going to remember dry cough or the productive cough at the end of the day. You might not remember it at the end of the week for sure. But when you're using AI Scribe, it's less cognitive load that you don't have to write the note from scratch. And because the note is written right there, you can also edit the note immediately. It would take you 30 to 60 seconds. So you can even do that after you have seen the patient, in between your next patient. And because you're using this, you're not looking at your screen, you're looking at the patient, so your attention is not divided. So that's another big before and after AI Scribe workflow differences. So some of the lessons we learned from this particular example is that using structure even in your verbal output would improve AI accuracy. Speaking important negative would help you make sure that the note is exactly the way you want it to be represented. Make sure that you review a note at the end of the day. If you skip a note, reviewing a note, there is a likelihood that you might have errors that could lead to safety implications down the line. And then finally, most importantly, right now, AI is there to assist you, and you are the decision maker. Even though AI is putting an assessment and plan in there, it might add components of the plan that you didn't discuss with your patient. Just make sure that you remove those elements, because AI is not there to decide what should be the plan for the patient. These are not the kind of templates that you would use in your EHR that are predefined by your department. This is one of the places where you, I think, would have to look at your output, and this variability of the output can make it sometimes really hard. That sometimes the AI would make that mistake, and other times AI would not make that mistake. Other times AI would be 95% accurate. So keep that in mind. Finally, to end this talk, I want to review key takeaways. So some of the safety considerations that you want to ensure that you're taking away from this today's talk is that AI scribes are assistants we just talked about. They are not autonomous clinicians, so don't let them dictate your plan. It should not replace your clinical judgment. AI scribes are not responsible for errors in your notes. Most vendors will have that clause in their contract. They're not going to be liable. Using structure improves accuracy. Review is mandatory. That is the primary safeguard right now until we have better systems in place. And real efficiency would come from making sure that you're using this AI for your specific problem, and you using a workflow design where you're integrating the technology where it should be in the workflow, and asking your stakeholders, your providers, constant feedback, whether it is helping them or are they even using it in the first place. And most importantly, you need to do needs assessment with your providers and your patients, what they think about this technology. And then takeaways, which are legal and ethical considerations. Remember, there are wiretapping laws. Each state have different laws. Each country might have different laws related to that. When you're doing the consent, make sure that tell them their voice is going to be recorded. Address any data security and confidentiality concerns. For patients with the non-English speaking, patients with dementia, patients with multi-party visits, people with their family members present. So ensure that the consent that you're doing with everyone, and if multiple people are speaking, that might impact some accuracy of your notes. Ensuring that your notes are culturally sensitive. That is again your responsibility. And finally, regularly updating training and consent process as the technology and regulations are going to continue to evolve. Thank you for listening. We can proceed with the Q&As.
Great. Thank you so much, Dr. Verma, for your talk. So we already have some questions I can ask you. Um, One of the questions says, do these apps autocorrect or hallucinate when dictating? What are your thoughts on that?
Yeah, so that's a good question. So I think a lot of work is being done right now. I cannot say behind the scenes because a lot of these vendors, their models are proprietary. So I don't know what exactly they are doing. But in the research setting, there are a few ways to prevent hallucinations. There are some specific prompt strategies that people are using that you can use to reduce the number of hallucinations. You can be more strict about specifying only use the data that is present in the transcript or things like that. Um, but what each vendor is doing, or many different vendors, even the large vendors in this space, I don't know what exactly they're doing, but there's some work that is being done for this.
Okay, great. Thank you so much, Dr. Verma. So there's another question. Just give me a second. Let me find it. Okay, so um, it says, does saying more clinical jargon aloud during the patient visit impact the patient's perception of the clinician's presence or engagement? For example, if the clinician says no long sounds bilaterally or says afebrile, is very clinical language rather than how I would normally expect a clinician to talk to a patient.
Yeah, that's a really good question, and I would explain this with the way we do medical education. So right now, when I see patients in my practice, inpatient or in the clinic, with the medical student or a resident or an intern, I am also explaining medical stuff to them. I'm explaining like, okay, I'm listening for the hard sounds. I'm gonna listen for S1, S2. I'm gonna listen for a murmur. This is a patient I'm working infective endocarditis. I'm listening for specific murmur in this case. Um, in my experience, personally, uh, it hasn't had any impact in terms of like patients understand that you're doing this for a particular purpose. So they understand that this medical jargon is not to explain things to them. You're going to explain things differently when you're talking with the patient, when you're explaining your plan to them. But this is something that you're doing with the medical student or with your intern. So I think from that perspective, they do understand. And when you explain it to them that you're using AI Scribe, and the reason you're saying these things out aloud is to ensure that the notes being written are accurate. I think, in my personal experience and based on some of the studies that I've seen that were coming from the like open notes project in the last decade, patients prefer that their notes reflect accurately what was discussed, that the notes are not over specifying or over making up information, like, or adding information that was not part of the conversation. So in my experience, I think that would be probably beneficial. But I do take the point that the medical jargon that you're going to use, there's been another study that has shown that if you, when you're talking with your patient and if you're explaining something to them and you're using medical jargon term, even a single wrong word can lead to distrust, or even in some cases, patients would outright check out and they would like stop listening to you if you're using words like, oh, your volume overloaded or things like that. So point is taken. Oh, I think you're muted.
Oops, sorry. Okay, so I was just explaining to you that one of our attendees has written a comment, and one of those comments was about so it says that the vast promise of AI in medicine and AI scribes, as an example, are being used to get more from less. So, for example, squeezing more productivity out of clinicians instead of using AI in medicine to provide leverage or to improve healthcare. What are your thoughts on this?
Yeah, that's a, good point. And so going into the informatics subspecialty, that's one of the things that from the informatics perspective, like not from the doctor's perspective, yes, we worry about that as a physician because now you're using a technology. But as an informatician, we worry about we're like happy with any new technology, any shiny technology that we see as informatician who are technophiles, but at the same time we understand the unintended consequences. So whenever you're going to implement this technology, it worries us that yes, it's going to increase productivity, and that's going to make your hospital CEOs or higher ups in the institution to tell you, okay, now you have saved 2 hours or an hour in a day, why don't you see three more patients or things like that. So it is one of the worries. I don't have the right answer. And at the end of the day, I mean, each institution is going to do things that the way they want to do. I think it's up to some of the clinician or physician organizations to figure out what sort of checks and barriers should be. When Epic, or sorry, I'm using Epic as an example, I should say EHRs came out and a lot of places implemented EHRs. The expectation was that before EHRs, we were using paper-based system. So there were less expectations to know patient's history or a lot of the patient's history in the chart. But now that the EHR is there, there's this large amount of data. Then if you're making a mistake or if there's a safety issue, then why didn't you review this? Why didn't you review that? So those type of unintended consequences of the use of technology. And one of the biggest worry that we as informaticians have is that using this technology is going to lead to some people thinking like, okay, how can we cut cost? How can we have the same number of providers see more physicians? Sorry, more patients. But I have also seen examples where at least in the early stages, institutions understand. At least I'm at one of the academic centers where they understand that the problem that we're trying to solve is a clinician cognitive burden to begin with, and giving them three extra patients at the end of the day is not going to help in any way with the burnout. Because then there's also another aspect of this, which is like post-pandemic or around the time of pandemic, a lot of providers started leaving their practices. The practices become untenable, especially with the patient portal systems where patients could send messages to the doctors. They were getting like 300, 400 messages per day. So each technology will have unintended consequences. We don't know all of those consequences, what they're going to be. There are unforeseen consequences. Hopefully, over the next couple of years, we'll have more studies, more data to tell us what can happen, what are the bad ways to do this technology. And I'm just hoping that we stay away from that type of practice.
Great, thank you so much. And I will say we take one more question before we conclude the webinar. And there is a question from an attendee that states, where is the audio file usually saved in the AI Scribe app? And does deleting the audio file solve the issue?
So I can tell you a little bit of what the general knowledge is. Of course, I cannot talk about specific vendors, but a lot of the time, the audio file and the transcript is saved with the vendor. And I think a copy of that is also saved with the institution. But that is not always the case that the copy is going to be saved with the institution. Right now, physicians or clinicians, they do not have access to the transcript. A lot of the places, even at our institutions, clinicians cannot access transcript. They are asking for it. It might be beneficial to see the transcript to improve the accuracy or some qualitative work for down the line. Sorry, the quality improvement work down the line. But when these transcripts and audios are saved with the vendor, I would say that they're saying that they're saving these for 30 days. And after that, all of those. Now, is it happening in the real practice? I don't know the answer. Now, the other question is, why are they saving it? Well, they're saying that they want to improve this technology. They want to improve the quality of the notes that they're generating. They want to work with you on reducing these biases, some of the limitations that we just talked about, reduce the number of hallucinations and omissions and things like that. How they can improve that, this audio and the transcript gives them that opportunity to do internal quality improvement. Um, how many of them are using it for those purposes and what they're doing with those recordings? I don't have the answer to that.
Great. So thank you so much, Dr. Verma, for your talk. Unfortunately, we've approached the end of the webinar. We would love to hear more from you, but you've given us such great insights. And
Absolutely.
yeah, so thank you so much for your talk and all of your insights. We really appreciate the time you spent to prepare this webinar. And thank you so much to our audience. We would love to hear from our audience before you leave how useful you found this webinar from a scale of 1 to 10. There's a poll to the right of your screens. So please let us know how useful was this from a scale of 1 to 10. You can vote. Yeah, so just let us know your thoughts. And another thing that I wanted to mention to you guys was there's currently a button to the bottom of your screen, and I can show you actually what this button has. So, sorry, just a second. I'm trying to share something with everybody. All right, so there's this button to the bottom of your screen, and this is just like our Mid-Mastery AI Hub. And basically, you get like an exclusive offer for attending our AI webinars in general. So any AI webinar you attend, you get this offer 30% off of Med Mastery Pro membership, and currently we'll also have it bundled with Consensus, so you get it for free for 1 year. And here are some instructions on how to redeem the Med Mastery Pro membership together with Consensus. So you have to use the code AIWeb626. This page also has all of the recordings for all of our AI webinars, including this one. So in case you want to watch any of the parts which Dr. Verma was speaking about, you can go ahead and watch the recording by clicking over here. We also have some additional AI resources, such as our ChatGPT Essentials course, which is done by our CEO, Franz Wiesbauer. And also, we would love to collaborate with people. So if you liked this talk and you also want to do a webinar with us, or maybe there's an AI tool which is super useful for clinicians that you want to speak about, please just fill in this form and reach out to us, because we're always looking for ways to collaborate. Yeah, so just click the bottom to the bottom of your screens and you have all of this information available to you. All right, so I'm going to stop sharing. So thank you again, Dr. Verma, for your time, and I hope everybody enjoyed this webinar, and I hope to see you guys at our next webinar. It's going to be on April 22nd. You'll get a notification per email.
Thank you.
Okay, so thank you, and have a nice day ahead.
Thanks. Bye.
Bye.